Esther Kissling is running the iMove network and will tell us a little bit more about multicentre studies for vaccine effectiveness in Europe. Esther.
Thank you, Alain. I'm delighted to be here on behalf of the iMove multicentre case control study to present the results from the previous season. So let's see how this works. So the iMove study aims at monitoring vaccine effectiveness in Europe. And it's been ongoing since 2008-09, so I'm presenting the fifth season results. One component of the iMove project is a multi-centre case control study. And in 2012-13, 7 countries contributed case control studies to it. They all used very similar protocols, so we could pool their data and do a pooled analysis to obtain a summary vaccine effectiveness estimate with a sample size big enough to provide early estimates and also stratified estimates. It's a test-negative design, so GPs systematically select patients to swap among patients who are consulting for an ILI or an ARI. These swaps are then laboratory confirmed. Those patients with a positive swab for influenza are classified as cases, and those with the swab testing negative are the controls. In our study, we only include those who meet the EU ILI case definition and who are swabbed within 7 days of symptom onset. The study period began more than 14 days after vaccination campaign in each individual country and ended on the week of onset of the last case, followed by at least 2 weeks of no cases. And we consider somebody as vaccinated if their symptom onset was more than 14 days after vaccination. Otherwise, they're classified as unvaccinated. This season, we did a complete case analysis, which means that we drop records with missing values, and vaccine effectiveness is calculated as 1 minus the odds ratio times 100 using logistic regression. We did a pooled one-stage model, so we put the study site as a fixed effect in our model. Now, this means that we consider that the vaccine, or the assumption is that the vaccine effect is the same in each study. We adjust, so we adjusted for age using a restricted cubic spline, we adjusted for sex, we adjusted for chronic conditions, and for week of symptom onset. We did the analysis by influenza type and subtype, by 3 different age categories, and this season, for the first time, we also analyzed the data by vaccine group. Sample size was only big enough to do this by split virion and subunit vaccine. So, we received nearly 8,000 swabs from the different studies. After applying exclusion criteria and dropping records with missing data, we had about over 3,000 records for the AH3 analysis and for the AH1 analysis, and over 4,000 for the influenza B analysis. We had to drop a few more records with missing data on vaccine group, but not very many. Looking at the number of cases by influenza type and subtype, by week of symptom onset, you can see that in Europe, this past season was characterized as a long season, with, interestingly, the majority being influenza B, with a long peak there to be seen. We compared our cases and our controls, but what's interesting to note is also the differences between cases, certainly in terms of age group. If you look at the influenza B cases, the median age was 15 years, whereas it was older for the influenza A subtypes. Although if you look at influenza AH3, the median age is 20, but the interquartile range actually starts at a lower age than for influenza B, and that's because there were actually quite a few very young cases of influenza AH3 in our data. Controls were more likely to be vaccinated than cases, which is a good thing. They were also more likely to have a chronic condition. There was not really much difference between the proportion of females and males in the different groups, nor really a difference in terms of people who are swabbed within 4 days of symptom onset. And controls were more likely to belong to the target group for vaccination. So what about the vaccine effectiveness results? The results for influenza B, the adjusted results, were around 50% in all age groups, and similar for AH1N1, and slightly lower for H3N2, at about 42%. But it's very important not just to have the type and subtype specific estimates, but also the age specific estimates by type and subtype, which you can see in this graph. Overall, similar to the study also by Karina, we see a low vaccine effectiveness for inactivated vaccine amongst the younger age group. And quite a big difference then, certainly for influenza B, between the younger and the adult age group, which was slightly higher. For the elderly, we had a low sample size for the different influenza A subtypes. So we present here only the crude estimates. For influenza B, the estimate was around 40% amongst the elderly. As mentioned, we also calculated vaccine effectiveness by vaccine type, so for subunit and split virion. Looking at all ages, for influenza B, the vaccine types performed very similarly, around 50%. But there were some differences for H1N1 and H3N2. Of course, as you saw from the previous slides, we really need to have age-specific and subtype-specific estimates, but it wasn't possible to stratify even further and not overfit the model. So what I present on my next slide is the age-specific estimates, but against any influenza type. And there we see that the results are more similar between the different vaccine groups. So, the 2012-13 season was a very long season in Europe with substantial proportions not only of influenza H1N1 but also influenza H3N2 and in particular influenza B. The vaccine effectiveness for all ages was around 50% for all types and subtypes, ranging from 42 to 50%. And the vaccine effectiveness was slightly higher among 15 to 59-year-olds, ranging from 44 to 64%. And it was lower amongst the younger age group, ranging from 22 to 36, 37%. Not all study sites collected information on doses, so we don't have this information. And we had low sample sizes amongst the elderly. It was possible for us to measure vaccine effectiveness by vaccine group. The data completeness was very good for this variable, and we actually have brand-specific information. There was a suggestion that vaccine effectiveness between split virion and subunit was similar for B, maybe slightly higher for subunit for influenza A, but we really need to have influenza type, subtype, and age-specific estimates to have a valid comparison. And what was important, particularly for this 2012-13 season, is that the sample size was large enough to estimate type, subtype, and age-specific estimates at the same time. To conclude, vaccine effectiveness in this past season in Europe was moderate, but the vaccine still remains our best preventive measure, which is important to underline. And it would be very important to routinely collect virological information in the vaccine effectiveness study on an individual level to really try and understand the variation in vaccine effectiveness estimates. And sample sizes need to increase even further to obtain vaccine type specific estimates by influenza type and subtype and by age group. I'd like to thank the iMove multicentre case control team for their wonderful collaboration, for their scientific rigour and for their enthusiasm. Thank you very much.
Thanks very much, Esther, for a very nice presentation. May I just add that the iMove multi-center case control study is now the biggest study carried out around the world with 8,000 specimens taken, and this without any funding from the European Union. So I think the country should be really thankful for that. The floor is open for discussion. Annika Linde.
Thank you for the nice presentation, and I know how well iMove is functioning. I'm wondering though, we vaccinate, at least in Sweden, to prevent severe disease, mainly characterized as hospitalization and intensive care. Do you have any intention to widen your prospects to take care of that as well? Because I think it's important to see and to get data on that protection, more secure data than existing.
Thank you, Annika, for your question. And I agree it's important to have this information on all different parts of disease burden, hospitalizations, death, etc. And the iMove project, the one that I'm talking about, looks only at GP-based, at the GP-based population diagnosis, but there's also a hospitalized test negative design study that is carried out on European level in several different European countries. I think many of the people are in fact here in the audience who contribute to that study. So that's also measured with a European network.
Yes, and there will be a presentation on that, I guess, tomorrow by Marc Randy. Yeah.
Yes, it's tomorrow between 1 and 3 p.m.
Okay, thank you, Esther. I find it's a very interesting work that you do. Can I ask you, your controls had a higher proportion of them were people in chronic disease groups that should have been vaccinated. And in the older people, you showed a big difference to the younger people. Therefore, you have a variable there, which is I'm more likely to have had the vaccine last year as well if I'm a control. How do you adjust for that? Because surely that affects your figures. And you did say crude and adjusted in one of your slides, and I wasn't sure what that adjusted really meant. Perhaps this is the same question.
Thank you very much. Those are in fact, given our study, two different questions. Your first question relates to previous vaccination, which is an incredibly interesting variable. And it's something that we do collect in iMove and have collected for the past 5 years. The thing about this variable is that it's actually quite difficult to collect in terms of good data quality. So that's one reason why we sometimes hesitate to address this, because we need to assess the data quality of this variable. Several studies have come out over the past years looking at this effect of previous vaccination, and some studies finding that, if you've previously vaccinated, then your vaccine effectiveness is enhanced. But on the contrast as well, there's many good quality studies coming out where you see the inverse as well. We have looked at vaccine effectiveness stratified, we've stratified vaccine effectiveness into somebody who's received previous vaccination only compared to no vaccination in the past 2 years, and people who've received only current vaccine and not in the previous year compared to no vaccination, and also people who received both vaccinations. And it's something that we can do, but I'd be very hesitant to interpret this in light of perhaps the poor data quality from this variable. And your second question was the adjustment, and that's, I think, on this slide. So in this particular season, we adjusted for age as a cubic spline. We adjusted for sex. We adjusted for chronic conditions, as in presence of any chronic condition and week of symptom onset. I'm trying to think of the results of what we received when we did the stratification by previous vaccination. I think we didn't see any reduction among people who had received both vaccines, but we didn't see much of an increase either. And it depended on type and subtype.
Jim?
Thank you very much for yet another fascinating presentation from the iMove group. I'm particularly considering the discussion that we had from a presentation of the information from Karina from Saxony, and now looking at the live vaccines coming along and being introduced for routine use. Certainly in the UK we recognise that as part of a significant challenge for the presentation of results, but for the pooled analysis that you and your colleagues are able to do across Europe, I can see this as an increasing challenge because we now have, for vaccine group, not just the age, but now live vaccine to consider too. That must prove a significant challenge for the patient numbers that would be required to look at the direct effect of the vaccine. How can that be addressed within the programme, given that, as far as I can see, there is no funding or limited funding available with host countries sustaining the burden for this?
Mm-hmm. Thank you, Jim, for your comment and for your question. More and more vaccines are available. We have now this live vaccine coming in. and was available in Germany actually in the past season. There's different modes of giving the vaccine, intradermal, intranasal, and all of these different things would be very interesting to look at, and would love to also get vaccine brand specific estimates. We had a great sample size this year of 8,000, nearly 8,000 records, but to be able to do this properly, and also to be, particularly if you're trying to choose the appropriate control group for a particular vaccine that's just aimed at a certain subpopulation, you need a much larger sample size to do this properly. And yes, we are challenged by the lack of funding at the moment. I think for the next season, and the LAC can probably be more precise than me, but sample sizes will have to decrease in some of the study sites that have been with us for 4 or 5 years, who really have excellent scientific methods and can provide so much to the study. I guess without further funding coming in, we won't be able to do these vaccine-specific or vaccine-type-specific estimates, which is a real pity. And also would like to provide more virological information on an individual level, which of course is very expensive as well.
Very good. Kari?
Thank you, Esther, for a lovely talk and important work. You know that I would like to see data on brand specific, and we have, besides the live and inactivated, we have adjuvanted vaccines, we have virusomal vaccines, and in the near future we will have universal influenza vaccines, and it may be only 5, 6, 7 years away. And have you started calculation on a sample size to be able to provide that kind of data? How much bigger would it be needed to be?
That's an interesting question. The sample size calculations are really quite difficult for this kind of estimation, because suddenly you're faced with a season when you have 3 proportions of important proportions of different subtypes. Now, if this past season had just been influenza H1N1, we would have had a really nice time with our analyses, but we had to do it by type and subtype. And for the different vaccine types, we had people vaccinated with adjuvanted vaccine, but so few that we felt we couldn't present the results without having with an unstable model. And with more vaccines coming, also, I think the challenge is to suitably recognise what the control group is for each vaccine, which stratifies the sample size even more. I guess what we could do is we could provide some worst case scenarios with 3 subtypes circulating, and with very narrow subpopulations for the different vaccine types, and provide them to get a good estimate, and provide a bit of a range, sort of a worst case and a best case scenario. But I would estimate we'd need twice the sample size to already do a good job on this.
That's an important question. Yes, please.
And of course, vaccine coverage plays a very big role. If the vaccine coverage was much higher, we'd be able to have better estimates already this season.
If we are moving, oh, there is a question on the back. Yes, please.
Yes, sorry, I'm sitting here in the dark, but nevertheless, could you go back to your results, please?
The first one?
Yes. I'm again very impressed by your fantastic study. Do you agree that your results are more or less in line with the recently published study in vaccine from, I call it the Rotterdam group, where they also indicate that they have a typical influenza-like illness vaccine effectiveness of 40%. So I think that is in line. And the question, of course, is that enough? The studies of Stockholm were criticized that they were, not welcome to be that critical. But in fact, you are confirming these not that optimistic results.
Mm-hmm. These results certainly are in line with that study. And what's particularly nice and heartening in terms of methodologies, our studies are in line with, for this season and previous seasons, they're very, very similar in terms of point estimate to the US and the Canadian studies. So much that one of the Canadian principal investigators said it's spooky how close iMove and Canadian estimates are. Is a vaccine good enough? I mean, 40 to 60%, is that good enough? It's the best we have. And also, if you think of the sheer number of people who get influenza, well, quite a lot of disease is protected, given that it's a very frequent disease. I mean, I would most certainly welcome a universal vaccine that has a higher vaccine effectiveness. But at the moment, it's still worth vaccinating, definitely. If it's good enough, I don't know, difficult question.
Okay, thank you.
Any other question? Yes, influenza is important. We need a much higher sample size. No, stay here, hey, please, Esther. We will applaud you before we conclude.
Thank you.
Thanks a lot for an excellent study.